Alright, this is going to be Chapter 15, the Respiratory System, Part 1. And the respiratory system here provides the body cells with the means of obtaining oxygen and eliminating carbon dioxide. And gas exchange occurs at the alveolar level. So whenever we talk about the respiratory system here, we're going to talk about, let's see, we have the lungs in here, trachea, glottic opening, ability. That's a little high to bring air in and gas exchange to occur here, which air would come into here. There would be tons of capillaries running across this alveolar sac, and O2 and CO2 would exchange in this area. CO2 would be expelled. O2 would go into the left side of the heart, pumped out to the body. So we're going to talk about the respiratory's involvement in this and what actually occurs. When we talk about gas exchange in the alveolar level, the alveolar sac is what we're talking about. Functions of the respiratory system: provide a large area for gas exchange between air and circulating blood, moving air to and from the gas exchange surfaces of the lungs, providing the respiratory surfaces from dehydration, protecting the respiratory surfaces from dehydration and temperature changes, and defends against invading pathogens. Since we're bringing air in, that's a foreign substance, the immune system is pretty strong in the lung area. We'll talk about that. Producing sounds and permitting speech, singing, and nonverbal communication. Providing olfactory sensation to the central nervous system, and this would be smell. Organization of the respiratory system: the respiratory tract, nose, the pharynx, the larynx, cystic fibrosis as far as a clinical note, the trachea, the bronchi, clinical note, bronchial angles, the bronchioles, and the alveolar ducts and the alveoli. Bronchiolitis, respiratory syncytial virus infections, the respiratory membrane, clinical note, pulmonary embolism, the lungs, clinical note, pneumonia, the pleural cavities, clinical note, tension pneumothorax and chest decompression, clinical note, tuberculosis, and then clinical note on tobacco use. The organization of the respiratory system. Major anatomical structures of the respiratory system are the nose, pharynx, larynx, bronchi, lungs, bronchioles, and alveoli. The respiratory tract is divided into two parts, the conducting portion and the respiratory portion. The conducting portion begins at the entrance of the nasal cavities and continues through the pharynx, larynx, trachea, bronchi, and larger bronchioles. The respiratory portion includes the smallest and most delicate bronchioles of the alveoli, and this is where your gas exchange is going to occur, and the actual alveoli. Alright, so we have all of these structures. We bring air in through the nose and mouth. This is our trachea here. Air is going to go in here. We have this thing called an epiglottis. It's going to assist us. It'll close, flip down and close whenever we're breathing, whenever we're swallowing, to let it go down to the esophagus. It flips back the other way and protects the glottic opening. We have the hyoid bone, which is important. The voice box, or the larynx. Trachea, which has cartilaginous rings. Esophagus is going to be on the back side of this. The pharynx. Internal nares. Now these things here provide turbinates. They also have mucus cells and mucus production in there. The immune system is pretty aggressive in this area. Nasal condi, which are little turbinate areas. Frontal sinuses. Nasal cavity. Nasal cavity is pretty large. And then sphenoid sinuses right here. When we talk about the alveoli, we're talking about the smallest portion You have veins and arteries that are encompassing these alveolar sacs. As oxygen comes in, gas exchange occurs so that we oxygenate the blood that's coming in and expel the CO2 that's going out. The nose. External nares are also called nostrils. Nasal cavity. Nares open up into a nasal cavity. Nasal vestibule. We'll look at this picture here again. Enclosed space of the nose. Hard palate formed by the palatine and maxillary bones. Soft palate. Fleshy bridge extends from the hard palate to the nasopharynx. Nasopharynx, which is above the soft palate. Nasal conchae, projections on the nasal cavity, and those are those things that we looked at just a second ago. The whole nasal mucosa is pretty much lined with mucus-producing cells, and they contain goblet cells, which are a part of the immune system. And frontal sinuses are here. Nasal conchae are there. Nasal vestibule. This is your opening or your nare. This would be your nasal cavity. Internal nare, this kind of opens up back here. This is your hard palate. It's got bone in it. Pharyngeal tonsils, and this would be a lymphoid structure. Palatine tonsils. Your oropharynx. The epiglottis, and we'll talk about these structures here in a second. These are part of the larynx, actually. Laryngopharynx, which is some larynx, some larynx, some pharynx. Hyoid bone, which is going to be important. This is for if we normally would look to the front. Thyroid, cricoid cartilage. This would be your cricothyroid membrane. Trachea, which is airway passage, and then your esophagus, which is food passage. Vocal fold is about right here, and the glottic opening is about right there. The pharynx, throat chamber shared by the digestive and respiratory systems. The nasopharynx connects the nasal cavity by the internal nares and extends to the posterior edge of the soft palate. Oropharynx extends between the soft palate and the base of the tongue at the level of the hyoid. Laryngopharynx extends between the level of the hyoid and the entrance of the esophagus. Laryngopharynx, oropharynx, nasopharynx. The larynx, glottis, larynx, epiglottis, thyroid cartilage, and cricoid cartilage are all, and I'll show all those to you. I just about showed them to you a second ago. They're easier to see on this next picture. Aretrenoid, corniculate, cuneiform cartilages supported by the cricoid cartilage. And when we're talking about the voice box at this point, the larynx, we have something at the top called false vocal cords. They're ligaments of in the upper. The two ligaments in the upper pair are known as false vocal cords, and they prevent objects from entering the glottis. So these things are going to close and assist us from closing the glottic opening. These are also what spasm in a laryngeospasm. True vocal cords extend between the thyroid cartilage and the aretrenoid cartilage. Small muscles that inserted on these cartilages change their position and alter the tension in these ligaments. Food, liquids that touch the vocal cords trigger the cough reflex. And then speaking about the cough reflex, in a cough, the glottis is kept closed while the chest and the abdominal muscles contract, compressing the lungs. When the glottis is open suddenly, they result with a blast of air through the trachea. If there's any material in that area, it ejects it out into the entrance of the glottis. So this will allow us to cough up or provide forceful air in case there is a foreign object in there. Okay, so if everyone will take a look at this area here first, this is going to be our false vocal cords. These are going to be here our true vocal cords. This is the epiglottis, which reminds me of, when you're looking at it, of a little tongue, but it closes the glottic opening. It'll flip up to this location here, or down to decrease the lumen in the esophagus. Root of the tongue, corniculate cartilage, which would be their top margins, as you would be looking for, and this is considered the glottis, or the opening. And these are actual pictures of it. Cartilage, epiglottis, false vocal cord, true vocal cord, root of the tongue. Clinical notes: cystic fibrosis. Goblet cells in the respiratory mucosa produce dense viscous mucus that cannot be transported by the cilia, and the cilia are what actually move mucus and allow us to cough it up. They're finger-like projections that happen in the lungs. Cystic fibrosis is a congenital malformation that makes them make very, very thick viscous mucus. Clogged airways, making breathing difficult. Rarely make it past 30 years old. This is a child or an infant onset. Cystic fibrosis is the most common lethal inherited disease that affects Northern European descent. 1 in 2,500 will actually have it. Results from a defective gene on chromosome 7. I'm going to take a look at this here. This is in the actual trachea, and they have something, the mucus, the movement of mucus, which is out, and the ciliated columnar epithelium. They have these little hair-like projections here. The goblet cells are attached to, this is the white blood cell initiator of the actual trachea and lungs and tissue like that. It'll have a mucus layer on it, and lamina propria, which is the muscular connective tissue that's underneath it. This is an actual picture of it here. The finger-like projections help us move mucus and entrapped things in this area. Vocal cords and sound production. Air passes through the glottis, vibrates the vocal cords, and produces sound waves. That's how we actually make sound and can talk, is by adjustment of our oropharynx, our mouth and tongue, and sounds that are moving through our vocal cords. That's why if you have a foreign body airway and you're completely occluded, that you won't make any sound. So ineffective cough, inability to phonate or talk or speak. The trachea, tough flexible tube. Tracheal cartilages are C-shaped. Actually have some smooth muscle to the back. This would be the front. Back. We'll show you a picture of these here in just a second. C-shaped cartilages protect the airway from stiffening the trachea or occlusion. Trachealis muscle, smooth muscle that controls the lumen of the trachea, and in bronchospasm or asthma attack, this can actually spasm and decrease the lumen of the airway. So this right here is what I was talking about. These here are cartilaginous rings. They keep the lumen open. Trachea, larynx, voice box. Hyoid bone is a bone that's kind of suspended just below the tongue and before we get to the glottic opening, and it's what most of our cartilage and ligament structures attach to for structural support. This is front. This would be back, or anterior, posterior. The esophagus runs down the back of the trachea. The bronchi, right and left primary bronchi, initial branches from the trachea. These are the main branches. So trachea, right and left. Bronchial tree branching into smaller airways, and that's going to be something like this. Secondary bronchi, bronchi that enter into the lung tissue. So you'll have, let me clean this up a little bit. I actually have secondary bronchi. This is going to be the lung. And then from there, bronchi that enter into the lung tissue, secondary bronchi. And then tertiary bronchi, 9 to 10 divisions after the secondary bronchi. So all of these are going to actually get to the lung tissue itself. And then a bronchioli, distal passage way before the alveolar ducts. And this is going to be the actual tissue that we exchange gas in, the alveoli and the alveolar ducts. Clinical note, bronchial angles. The division of the trachea into the right and left main bronchi occurs at the carina. So this thing, this breaking point, or this pathway that goes left and right, this area here is called the carina. Right primary bronchus angulates less than the left. Foreign bodies generally get stuck into the right. So what that means is the right kind of looks like this. We get an angled on the left. That's also why whenever we're intubating somebody, that it's very easy to put it in the right main stem. Can act as a one-way valve, and intubation generally occurs if we push it a little bit too deep past the carina into the right main stem. The bronchioles. Sympathetic activation leads to relaxation of smooth muscles in the walls of the bronchioles. Parasympathetic stimulation leads to contraction of the smooth muscles. So let's talk about this. The smooth muscles of the bronchioles, and these would be the medium-sized airways, not the alveolar terminal, not in the lungs, not in these airways that are in here, in between the two. And sympathetic stimulation takes the lumen and essentially opens it up. So the lumen is larger. Fight or flight, the actual receptor site is considered a beta 2 receptor site, or dilation of the smooth muscle. The parasympathetic nervous system, if it initiates a tone, what it does is it essentially contracts the smooth muscle. So what that means is that parasympathetic stimulus is going to take the lumen of those vessels, or the opening, and take them from this area here to this size here. The reason being is because we do not want irritating stuff in there. So most of the time whenever we get a bronchial constriction or an asthma attack, it's from a faulty trigger. If you set the ceiling on fire, the irritating gases could give you a bronchospasm. The reason is because the lungs, this is an autonomic response. They do not want foreign substance in there. They want nice clean air, not irritating poisonous air. And this is figure 15.6 in your book, and these are the smooth muscles right here, and these will either increase or decrease the lumen of the actual bronchioles, or the pipes essentially that are going to the alveolar sac. And this is where all of your gas exchange occurs, is down here in this alveolar sac. You also, if you'll take note, have lymphatic vessels in case, like I said, the lymphatic vessels act as a trash can in the previous. So at the point that you get a foreign invader in here, it can easily get them to a section to where the immune system can take care of them. The alveolar ducts and the alveoli. Alveolar ducts, bronchioles open into these passageway, alveolar sacs. Alveolar ducts ends into this structure. These chambers connect with the individual alveoli, alveolar macrophages, which are white blood cells, and they pretty much patrol the epithelium or the actual tissue that's there. Septal cells, and the septal cells secrete surfactant. Surfactant is very important. Reduces the surface tension, is what it does, and allows the alveolar walls not to collapse. So without surfactant, this air sac that's down at the terminal end here could collapse and not open back up again. The surfactant allows it to stay open so that we can move air in and out of there. Respiratory distress syndrome. Loss of the surfactant requires the alveoli to pop open for every ventilation. And this will make a popping sound, crackles, or another thing that whenever you're listening to lung sounds that we'll talk about in assessment. So alveolar macrophages are here. We have capillaries, septal cells that secrete surfactant, elastic fibers that are running in here. This is the epithelium that is in that area, and it's very thin. This allows for good transfer of gases. So whenever air comes in, it passes across these, and it works like a balancing act. Diffusion is occurring. This is the alveolar sac wall. There's more oxygen. 6, 7, 8, 9, 10. Then there is in the returning. This is in the returning area. This is our CO2. So essentially CO2 is going to go this way and oxygen is going to go this way. And it's going to do this until they're balanced on both sides. So what there will be is on both sides of this membrane, there's 10 of each here. So there will be 10, there will be 5 CO2s on this side and 5 CO2s on this side, 5 O2s and 5 O2s. So we're looking for balance, and that's all that that semipermeable membrane allows, is for things to balance on both sides. If you'll remember back from our previous lecture, from an area of higher concentration to an area of lower concentration. The same could be said about CO2. Higher concentration in the return, lower concentration in the supply in the alveolar sac. So what we're going to get is we're going to get movement in both directions. Clinical note, bronchiolitis and respiratory syncytial virus. Bronchiolitis is inflammation in the smaller airways, common in children less than 2 years of age, most commonly caused by the RVS croup. I'm sorry, this should be RSV, respiratory syncytial virus. RSV, respiratory syncytial virus, common virus epidemic in the winter months, and we generally see these in the fall. In the winter, kids start getting this. Nice thing about that is you have cool air outside. So if a child comes up with bronchiolitis, so most of the times, if the parents can just bundle them up a little bit and get them some cool air, the cool air will decrease the size of the airways and help with the acute onset of respiratory distress. If that does not occur, then obviously we will have to come there and get ahead of the physiology. Things like albuterol treatments to open up the airways, IV fluids if they are dehydrated, and so on. The respiratory membrane. Respiratory membrane consists of 3 components: the squamous alveolar epithelium, the endothelial cells that line the adjacent capillary, the fused basement membranes that lie between the alveolar and the endothelial cells. So alveolar epithelium, surfactant is going to be here. This is a fused basement membrane, and this is the capillary lumen. So we're not talking about a very large area. We're talking about 3 cell layers thick for the entire alveolar sac. They're very delicate and tender. A good pop to the chest could cause pulmonary contusions. That would only mean that we have bleeding in this area. It's got a pretty good vascular supply, so bleeding is pretty common. Clinical note, pulmonary embolus. A pulmonary embolus, or PE, usually is caused from a DVT, so we're down here in the foot. That's a Sasquatch foot, by the way. And we develop a clot in the actual venous supply. Now, what that'll do is it'll cause swelling to this foot in an isolated area. The thing is that the veins returning usually get larger on the way up. So if this dislodges and starts moving, does it make sense that this can easily get thrown through the pulmonary circuit? The problem with that is you have kind of one static opening here in the right ventricle. You have the pulmonary artery. So that clot comes in and it gets lodged into there. No more blood gets circulated through the pulmonary trunk. That becomes problematic. Patients generally will get a blue line from about the diaphragm up. They generally will go into PEA. No more blood gets circulated through the pulmonary trunk. Fairly devastating, rapid onset. Partial PEs bother us as well because it cuts off very large sections of lung tissue that we can exchange gases on. If we had a smaller PE that could actually fit through this initial opening, this would be a total, and the patient will be in full arrest if it blocks the entire area. But if it's smaller, it'll get lodged into some of the smaller vessels and cut off blood supply or exchange supply to very large sections in the pulmonary circuit. The lungs. Two lungs have distinct lobes that are separated by deep fissures. Right lung has 3 lobes and the left lung has 2 lobes. That's because on the left side we're kind of displaced by another organ, which is the heart. All of our vessels and stuff would be coming out of here. So the right lung we can have another lobe on. As far as the left lung goes, we actually have a cardiac notch in it. This is the mediastinal area. This is a cross section from the top with the heart in place. Left lung, right lung. 3 lobes, 2 lobes. Esophagus is here. This is the spine. Clinical note, pneumonia can be either from a bacterial or a viral cause, and it pretty much, does it make sense that we will get pyrogens from an invading form here? Weakness because we have a loss of the ability to oxygenate because it's set up in our lungs. Deep productive cough, fever, and chills. Viral pneumonias and fungal pneumonias are pretty rare. Your immune system has to be beat back pretty good for it not to respond to initiating viral signal. The T cells and B cells will generally recognize that pretty quickly, and that's because of histocompatibility complex 1 or major histocompatibility complex 1, and that would be in the previous chapter. You do not have a free access pass. Now you look foreign to me and I'm going to destroy you, signaling from the immune system. So pneumonia, quick onset, it used to be called the old man's friend. Pneumonia can kill people. It causes a breakdown from the bacteria of the alveolar sac, and this will allow extracellular fluid to flow back into the alveolar sac, giving them rowels or crackles. Pleural cavities. Parietal pleural covers the inner surface of the body, and the visceral pleural covers the organs. And if we'll just make note to this at this point one more time, I think I pointed this out before. Anything that says visceral pleural, pretty much is touching the organ, viscera, organs. Clinical note, tension pneumothorax and chest decompression. We want to hit the midclavicular line just over the third rib. And the reason that we want to go just over the third rib is because we have vascular structures that are running up here. If we get too high into this area, we can hit them. We do not want to go under because of this, that we have a vein, artery, and a nerve running under every rib. So again, we use the rib, third rib, as a marker and go just over. If everyone will please take note, your first intercostal space is hidden by the clavicle. This would be your second, third, just over the third rib. Clinical notes, tuberculosis. Mycobacterium tuberculosis, bacteria that causes tuberculosis, may infect any tissues, not only the lungs. So they can actually get TB in your kidneys, in your liver, a lot of areas. Worldwide health problem, transmitted through casual contact and spread through the air in tiny droplets. That's why a mask is important if you think that someone has TB. Treatment may require 6 to 24 months of actual antibiotic therapy, and that's because the stuff just is hard to kill. Mycobacterium cell walls are resistant to normal antibiotic therapy, so you have to get something, a very powerful antibiotic that sticks around for a very long time. And this is the actual nasty little bacteria. Plate. Clinical note, tobacco abuse. It's rated in pack years. It's an irritant. It gives people bronchospasm. It leads to something called COPD. We'll talk about that in part 2. We rate people in pack years and determine the number of packs smoked per day and the number of years the patient has smoked. So a man that has smoked 2 packs a day for 15 years, 2 times 15, has 30 pack years. This concludes part 1. If you have any questions, feel free to call me. My name is Roy Smith, 405-219-7613, or you can reach me at smithr@imsa.net. Thank you.